Good afternoon, everybody. I would like to ask for your patience just for a minute or two, because we have the new registration system. I think there's a few people that will be joining just a minute or two late. So we'll be starting soon. Hi, Johan.
Good afternoon.
Nice to see you.
Yes, thank you. It is nice to be able to join.
Actually,
So
looking
we'll
at my
give
watch, it's still 15:59
few
and it's 4 o'clock now. So just give it a minute or so. And let's just get everybody on board. Okay, I think we can get going. So good afternoon, everybody, and welcome to this week's deep dive. It is a great pleasure to have all of you here. And I would like to, sorry, just get my video on, extend a special word of thanks to the Blood SA team. Today is the first day that the deep dive is hosted directly from Blood SA's system. For those of you who haven't visited Blood SA and the website before, I really want to encourage you to do so. All the recordings are now hosted on that website, and we will show you the link just now, but we can perhaps also put it into the chat box. Nevertheless, just to remind everyone, the weekly deep dive is really there to help our trainees. And I must say, having been an examiner in the recent college exams, I could really see that the deep dive has impacted people's knowledge, and the level at which things were presented, generally speaking, was really great. And I'm even more excited about deep dive going forward, noting the benefits that I think we are accruing as a, I think if there was a something like an IQ or average hematology quotient for the country, I certainly think all of our HQs or whatever is increasing. So today I have the privilege of having Professor Johan Potgieter from the University of Pretoria here today. And Johan is going to chair this session. Johan, thank you so much for coming. I've known Johan for a long time. Johan has got a great passion for bleeding disorders. He, of course, knows a lot of things about other things, but I think this is the one area in which I've really seen him come alive. And it's great, Johan, to have you with us. I also maybe need to mention, and Johan, maybe, I don't know if you want to say something about it, if you want to use the opportunity to say what you hope to do with University of Pretoria and hematology, but I'll leave that to you. If you...
I would not want to say anything about that now.
Okay,
I think
100%.
I will keep it for a future
100%.
engagement.
Fantastic. Good. So Johan is head of hematology at the University of Pretoria. As you can see, qualified as a hematopathologist in 2008, and with a special interest in laboratory hematology and bleeding disorders. I'm going to hand over to Johan in a second, just to let everyone know that this is a CPD accredited session. So if you've registered for the meeting, then we should have your details. The recordings can be found on the website, as you can see here. We want to really encourage you to add questions to the checks and also contribute to the discussion a little bit later on. And we'll have a little survey at the end, which will take you lessons. If you can just fill that in, which is the confirmation also for your CPD that you've been here. Great. Over to you, Johan.
Yes,
You
thank
are
you.
welcome to introduce the first speaker and the session.
Thank you so much for the opportunity. So I'm going to introduce only one speaker today, and it's Dr. Lumka Ntabeni. She's going to be a one-woman show. I know that she can do this. So I think South Africa has had a connection with Haemophilia B since 1952, when Stephen Christmas was diagnosed with Haemophilia B, and that's also, of course, still associated with Haemophilia B is the name Christmas. And of course, he was South African patient. So I would like to introduce Lumka, and she's going to speak to Haemophilia B and whether it can be naturally cured. Lumka is a senior hematopathologist in our department, and she's a very valuable member of our faculty. She has a special interest in bleeding disorders, and she manages our patients in the hemophilia clinic also with bleeding disorders. But she's more diverse in terms of that. She also has an interest in quality management in the lab, and she's also a qualified SANAS technical assessor. So a lot of different aspects that she brings to the table, and she's going to speak to first a case study and then a presentation on Haemophilia B and whether it can be naturally cured. Thanks, Lumka.
Afternoon, everyone. Johan, can you just confirm if you are able to hear me?
I can hear you, and your slides are in presentation mode. Thank you.
Okay. So this afternoon, hoping to answer the question whether Haemophilia B can be cured naturally. But also I'm hoping to get input from the audience so that we have a longer time for discussion regarding the case that I'm going to present. So the outline of my talk will start with the case, then I will do the molecular basis of Haemophilia B, then dive into specifically Haemophilia B laden. And then, as I say at the end, I'm hoping we'll have fruitful discussion. So the case at hand is patient QT, who was referred to us in March 2022. He was a 16-year-old male who, according to the referral, was known with the diagnosis of Haemophilia B. He was diagnosed at Charlotte Maxeke Hospital in 2017. Between 2017 and 2022, he had defaulted and had presented at Rob Ferreira Netspruit prior to them referring him to us. According to the clinician who contacted us, he had presented at Rob Ferreira with swelling of both knees, which they had referred to as hemathosis. In response to this, and with the prior diagnosis of Haemophilia B, they then gave him Hemosolvex, and he had an anaphylactic reaction. This was actually, there were two attempted challenges, and in both instances, there was a full-blown anaphylactic reaction. By the time he came to our clinic, they tested for inhibitors, and there was no evidence of inhibitors. They'd done a full blood count, which showed a hemoglobin of 11 and white cells of 10 with platelets of 279. There was also a CRP of 205. They had given him prednisone for about 5 days. And then he got an appointment at Steve Biko at our clinic. So when he came to us, most of the history was from the mother. And according to the mother, she confirmed that he was diagnosed in 2017 with hemophilia B after having presented at Tambo Memorial with a left knee bleed. There was no family history of hemophilia. He had been using Hemosolvex on demand whilst he was at Charlotte, and he had not had any reactions. The left knee was the target joint. And then in 2018, he moved to Mpumalanga to stay with his dad. According to the mother, whilst he was living with the dad, there were no follow-ups up until he moved to stay with her at the beginning of this year in 2022. Also, according to the mother, when he presented to Rob Ferreira, there was no bleed. He had been diagnosed with COVID, and she had taken her to Rob Ferreira for treatment of COVID. She believes they gave him Hemosolvex because she mentioned the history of hemophilia B. This is according to her story. So when he got at our clinic, he weighed 50 kilograms, normal blood pressure. He looked generally like well, but he was very shy. There was no jaundice or pallor, no bruises, he had no lymphadenopathy, and the rest of the examinations really didn't reveal anything of significance. The relevant examination of the musculoskeletal showed a normal gait. He had obvious swelling of the left knee, and he actually had a fixed flexion deformity of the left elbow. This is just a picture showing his left knee and the elbow. So at this visit, we did some baseline bloods. Just to note that amongst the bloods that we did was a factor 9 level. And that first factor 9 level came back as 146. We had also ordered x-rays on the first visit. And these are the pictures of his left elbow, his knee, and right ankle, which showed arthropathic changes. Pedigree was done assistance of Judy Milan, and he, as I mentioned, there's no family history of hemophilia B. This was a spontaneous mutation. So he came back in April for follow-up and obviously a review of the blood results as we had done the blood workup at the initial visit. So we thought the 146 factor 9 level that we got on the last visit may be related to the fact that he had had Hemosolvex at Rob Ferreira. So we repeated the factor 9, but in addition, we also requested factor 8. At this point, the factor 9 level was 114. This was now more than a month after the last dose. And his factor 8 level was 187. I then contacted Charlotte to try now and get the file to go deep into what happened at diagnosis and if they had any information that could assist us. And I also contacted Johnny. So from the file at Charlotte, he was actually seen as a referral from Tambo Memorial. He had presented at the age of 11 in 2017 with a left knee swelling. This was after a traumatic event. He was playing soccer and somebody had kicked his knee. After extensive investigations, they came down to diagnosis of hemophilia B, and his baseline factor 9 at that point was 12. There was no previous history of joint swelling or any bleeding abnormality. He had no family history of bleeding. He had had a circumcision in 2015, and according to the mother, this was uneventful. And at that point, the relevant exam was a left knee and left ankle that were both swollen and warm to touch. And the left knee, there was reduced range of movement. He was started on Haemophilia on that admission, which he responded well to, and there were no reactions. He was cancelled on the new diagnosis. If you go through the file, he had 1 or 2 visits after the diagnosis, both presenting with left and on the other visit with right knee bleed. Both were treated with Haemophilia and they were uneventful. This is just to show you the bloods from 2017. So this was the level of 12, which was done whilst he was at Tambo Memorial. And I just want to confirm that I did actually see these results on track, so there were no transcription errors. So the baseline was 12. They had also checked factor 8, which was 128 at that time. When he came to Charlotte, he had received Haemophilia, so his factor 9 was around 195. And they do indicate in the notes that they waited for that to clear, and the follow-up factor 9 level was at 27. But what I noted on both these instances is that his PTT, which was done both in October and November, based on their reference range, were normal, which I thought it was a bit strange, but we can always discuss it, that he had a level of around 12, yet it did not affect his PTT. Now, having spoken to the patient, when he actually moved to Mpumalanga to stay with the dead, he did actually attend Sabi Hospital. And I've confirmed this with notes from the hospital. Unfortunately, whilst he was at Sabi, there were no bloods that were done. According to the physicians from there, he came to their hospital as a referral from a local clinic already with a diagnosis of Haemophilia B, and all they were asked to do was to basically supply Haemosolvex, so they never did any blood workup. He then moves to stay with the mother beginning of this year. After I've done all the investigation now in terms of all the hospitals that were involved, he was called back for follow-up at our clinic. This is now around May. Of note is that when he came to clinic this time, he reported an episode of a left ankle and a left wrist bleed, which were treated with Novo 7 based on the reaction that was documented previously. And according to the patient, there was a good response to Novo 7. But having gone through all the files, I felt we needed to do a full workup because I wasn't sure what we were dealing with. So we basically did most of the bloods under the sun to cover any possible bleeding disorder. His INR was normal, his PTT was normal. The factor levels remained normal, both 8 and 9, even did 13 qualitative, which didn't show evidence of a deficiency. Then there were no inhibitors. We did a von Willebrand screen, both the antigen and the activity were normal. At this point, we're also thinking of a possibility of a misdiagnosis. So we did some autoimmune screens, including the rheumatoid factor, which also came back normal. The fibrinogen and the thrombentine were also normal. So Johan, whilst I was away, then he had a penny drop and he came up around this concept of a Haemophilia B laden, where patients with Haemophilia B recover their low factor levels after puberty. And this was now, could this be what we were dealing with? So I'm part of a group of the Haemophilia Academy, which has got clinicians from globally who deal with hemophilia. And at one of our meetings, I asked to consult regarding him. So they allocated me one of the clinicians from Paris, and we had an extensive discussion about his presentation and what was happening. So after that discussion, the differential diagnosis was this possibly a wrong diagnosis, and the patient actually had juvenile rheumatoid arthritis, or were we dealing with hemophilia B laden? So they were kind enough, they referred us to a pediatric rheumatologist that they work with in Cape Town, Dr. Chris, who then suggested a pediatric rheumatologist from Bara because of where the patient lived. He was then referred to Bara Pediatric Rheumatology, got an appointment in September and had a follow-up visit in October. At Bara, they did extensive examination, and basically their musculoskeletal findings confirmed what we already knew, the involvement of the left knee and the left elbow. They also did additional workup in terms of autoimmune investigations to what we had done. They also performed an ultrasound of the joints, and of note is that the rheumatologist was intentional about not putting a history on the request form for the person who was going to perform the ultrasound. So the ultrasound came back saying there were complex effusions basically involving all joints, and this was in keeping with evidence of hematorosis. All their blood workup in terms of rheumatoid factor and the other abnormalities that are associated with juvenile arthritis came back negative. So I'm going to stop at that point in terms of regarding the patient, and then I just want to discuss hemophilia B. So as Johan has mentioned, hemophilia B is a congenital X-linked recessive bleeding disorder. The first case was reported in 1952, which was Stephen Christmas. It has got the pathogenic variants on the factor 9 gene, which is located on the X chromosome at position XQ27. It comprises about 15 to 20% of all hemophilia cases. And generally, the feeling is that it's less common and less severe than hemophilia A. The prevalence is reported to be about 1 in 30,000 live births. It's divided into different severities, the same as hemophilia A, based on factor 9 activity, into severe, moderate, and mild. So the actual gene, the factor 9 gene, which is what it's called, was cloned in around 1982 to 1983, but the full sequence was actually published in 1985. It is regarded as one of the most studied genes. It spans 34 kb on the long arm of the X chromosome, as I said, at band XQ27.1. It has 8 exons and 7 introns. And basically, this is a schematic diagram showing the factor 9 gene structure and how it gets processed. So as I said, it contains 8 exons and 7 introns. And these get transcribed into a 2.8 mRNA sequence, which comprises of the coding region and flanked by the non-coding regions. The coding sequence then translates into what we call the factor 9 precursor, which has got all these domains. The mature factor 9 is basically once the factor 9 precursor has undergone different translational modifications, which include gamma carboxylation. And the inactive form is converted into the active form by cleavage of this area, which is the active peptide. And once this gets cleaved, then it becomes an activated factor 9. This is another schematic diagram which shows the protein synthesis of the factor 9 gene or the factor 9 protein in the liver cells. So the whole process starts in the cytoplasm. And basically you've got this peptide referred to as the N-terminal signal peptide, which is synthesized in the cytoplasm. And then we've got a molecule referred to as the signal recognition particle, which going forward I'm going to refer to as the SRP. So this SRP recognizes the signal peptide, and then it stops the translation of this peptide. Whilst doing that, it also directs this peptide from the cytoplasm into the endocytoid membrane. When it gets here, then the ribosome kind of restarts the translation. It goes through several steps, which I'm not going to go through because will be forgotten at the end of this talk. But the major step that I wanted to highlight is that we get to this stage where the propeptide undergoes carboxylation, then it is moved into the Golgi apparatus using membrane particles. And whilst in the Golgi, it then gets cleaved and becomes the mature protein that gets secreted into the circulation. So the protein is actually part of the group of what we refer to as the vitamin K dependent proteins. As mentioned, it's synthesized in the liver. Before it gets secreted into the circulation, it undergoes all these steps. And the main one that we're familiar with is the gamma carboxylation. There's other steps that take place post-translational modifications, but the significance of or the function of those steps is still not clear. The distribution of the mutations on the factor 9 gene can be, information can be accessed on this site. And this is the database that's relevant as from the January 2022. So in total, there's about 1,094 mutations in 3,713 hemophilia B patients. And these include point mutations, deletions, insertions, etc. The majority are point mutations followed by deletions. And then the small pie chart just shows the different types of the point mutations. So if we look at this table, which looks busy, but what I just wanted to highlight is that if you're thinking of your gene in terms of the coding and the non-coding areas, of all the mutations that are seen, 897 are actually in the coding area, and then 171 are in the non-coding area. Then you get mutations which are found at different multiple regions, and those comprise about 2.4%. Also, what I want to highlight is that when you look at the exons that are actually involved, when they look at the patient number versus the length of coding sequence, they calculate ratios, and they found that exon 2 and exon 8 are the mostly involved, which then indicates, if you remember what these, based on this diagram, what they translate into or what they correspond to, it then means that the propeptide, the JL8 domain and the SP domain are the ones that are mainly involved in the mechanism of basically factor 9 deficiency. So what are the mechanisms in factor 9 deficiency? These occur at multiple levels, and they can involve the gene structure or translation and the other steps. So in the coding sequence, we get deletions, insertions, duplications, insertions, and deletions, which result in a frame shift, resulting in basically the peptide being truncated, or you get extension of the polypeptide with a different or a changed sequence, and that will result in deficiency. Sometimes you can get an in-frame effect, which can cause a deletion or insertion of nucleotides in multiples of 3. And what they found is that patients with the in-frame or the frame shift mutations tend to have a severe phenotype. Can also get deletions and indels and insertions in the intron area, and those result in aberrant splicing, which then results also in a severe phenotype. You can also get gross deletions, which are not common, and these can occur in multiple regions, and these will result in a severe phenotype. And as we all know, the patients with gross deletions are prone to the development of inhibitors. But I want you to focus on and remember going forward is that we can also get mutations in the promoter region. And these, this is where the diagnosis of hemophilia B laden is based. So it's a mutation that's found in the promoter region of the factor IX gene. Now, in relation to all the other abnormalities of factor IX, I just wanted to highlight that it comprises about 2.32%. So currently, as in 2022, globally, there's about 86 cases that are described. Obviously, this is influenced by registries that they are getting the information from. So what is hemophilia B laden? So it was first described in 1970, where patients have got low factor IX levels at birth. And then as they grow up, there's a progressive rise in the factor IX activity level from puberty. There's about more than 20, around 26 genetic mutations that have been described. And all of them tend to cluster basically in the promoter region of the factor IX gene. There's specific nucleotides that have been described and that most patients tend to have. The common one being the one at position 34 and 35. So they say half of the cases, their abnormality or their mutations are in this area. There's also cases at C49 and C19. This was the first paper that actually described hemophilia B laden, which was published by Veldkamp et al. And basically it was called hemophilia B laden because of the sites where the research basically took place. So what they described is basically patients who showed a striking feature in that their bleeding phenotype disappears as they advance in age. And their levels were increasing from about 1% to about 20%. And they called it and referred to it as hemophilia B laden. If you then go into literature, a lot of it is case studies. So I've chosen some of the papers which I feel are important landmarks in ongoing research under the topic. So this was a paper which was also published by Veldkamp on the New England Journal of Medicine. And they basically followed up about 8 patients from a previous pedigree of families that they were following up. These patients, their age ranged from about 14 years, the oldest was about in the 80s. And what they observed was that in all of them, when they reached the age of about 14 to 15, their levels started to increase. The last patient was still 14 at the time when they published this paper, and that's why you're not seeing an increase. And basically the arrows indicate when they reach puberty. Puberty was described as the presence of secondary sex characteristics like pubic hair, etc. This is just a bigger version to show you that basically when you get to around 15, then there's a sharp increase in terms of the factor level, which tends to stabilize, as they said, around the age 20. And also what they mention is that the values usually rarely go above 30 to 40. They also, in this same cohort, in addition to activity, looked at antigen levels using ELISA-based assays, and they found that there was a good correlation between the activity and antigen levels. And based on this paper, their postulation was that the rise of the factor IX level, which occurs around puberty, is actually related to the male sex hormones. The rise was estimated to be about 4 to 5% rise per year, and all of the patients that they looked at were getting the rise between the age 15 and 16 years. The fact that there was a good correlation between the antigen and the activity made them to postulate further to say that post-puberty, when this now factor 9 level has risen, functionally it is actually fine and structurally it is fine. And that was based on the fact that the activity and the antigen were correlating. Then there was this paper, which was actually a letter to the editor. And this was of a 26-year-old patient who had been diagnosed with hemophilia B, and his baseline factor 9 level was 12. And he had presented at the age of 26 to emergency unit with an abscess in the quad. And during this visit, they started him on Hemosolvex, which was the normal thing that they would do with him. But what they noted is that he was not responding. He also gave a history of having started using some anabolic steroid. So this is just a graph to show you factor activity around this visit. So as I said, he was diagnosed at around age of around 13 months, and the baseline was 12. They hadn't done the actual sequencing of the gene to actually find out that he was hemophilia B laden. Then at the time, he then came to ER. At this point, they'd given Hemosolvex, and post Hemosolvex, what they noted is that he kept sustaining his levels of factor 8 at a higher, factor 9 at a higher level, even though this was not explainable by the half-life of factor 9. He was then, after mentioning that he was taking the steroids, he was asked to continue and take the steroids. And if you observe here, the more he was taking the steroids, the more the levels were going up. At this point, he was then asked to stop the steroids. And what they noted is that a year later, post the anabolic steroid use, his levels were still at 24. And then 2 years later, his levels were still at 36. And their postulation was that they feel that this supports the postulation that anabolic steroids may be contributing to the recovery of the factor 9 level, supporting the paper that was speaking about sex hormones also being involved. Then this group then came through with what I would refer probably as the landmark paper in terms of hemophilia B laden. And just to give a background, so as I have mentioned that most mutations are clustered in the promoter region, and with the numbering that was specifically used in this paper, they range from nucleotide 34 up to nucleotide plus minus 19. This area is actually now referred to as the laden specific region. And in a normal development, it's a binding site for these transcription factors, and it contributes to the transcriptional control of gene expression of the factor 9. As you know that when we are younger, our factor 9 levels are lower, and they tend to pick up and get close to normal values around when your kids get weaned. And these are the transcriptional factors that are responsible, and they bind to this area, which is now referred to as the laden specific region. So what the postulation is that then you get, if you get mutations in this area, you get then disruption so that these transcriptional factors are not able to bind to the area. And then this disruption then results in prepubertal hemophilia B laden. At the point when this article was published, this area had not been given a name, but later on it's got this transcriptional factor is now called a 1 cut and 2 cut. So what they were saying is that if you get disruption in these areas, you end up with hemophilia B laden. Now, the question was, what is the mechanism then that is causing the recovery of the factor 9 level based on that background? So they did a study to try and demonstrate that the recovery was actually related to growth hormone, and it had nothing to do with sex hormone levels. So what they did is they did transgene mice models. It's a very extensive paper, and I would recommend that people go and read it. But what they did was that they took these mice which had a hemophilia B laden phenotype. They performed surgical operations to remove the pituitary gland as the source of growth hormone. And they did tests to prove and indicate that there was absence of growth hormone. Soon as they had performed the hypophysectomy, there was definite drastic drop in the level of surrogate tests that were indicating the absence of growth hormone. They then injected them with growth hormone at different doses, and there was an obvious pickup of factor 9 levels. When they stopped the growth hormone level, there was also an obvious drop in the factor 9 levels. They then injected them with some sex hormones. There was a mild induction, which you can pick up here, which then also disappears in a few days. And once they reintroduce the growth hormone, there's an obvious peak of the factor 9 levels. They also had control mice, and these were just given some sesame oil, and this after the hypophysectomy. And as you can see here, there was no increase in levels of factor 9 levels. As soon as they introduced the growth hormone, the factor 9 levels picked up. Also at protein level, you can appreciate that the wild type, without the hypophysectomy, you can see and appreciate the presence of factor 9, but post the hypophysectomy, there's no factor 9, and once they've injected the growth hormone, then you can see the factor 9. And basically, what they concluded from this paper was that the mechanism that was involved with the recovery of the factor 9 levels was actually driven by growth hormone and not by the sex hormones. And also the mice that were here, they were both males and female mice. And so it took away the male sex hormone postulation. Then we get the paper, which was also a letter to the editor. And this actually looked at symptomatic female carriers with hemophilia B laden. This was published from Ireland, where they looked at their database, a national Irish database, and they investigated basically to check the age-related correction of patients who were diagnosed with hemophilia B laden. They found a total number of patients of 212, and out of those, they then narrowed it down to 13 carriers, and these were obligate carriers. And out of the carriers, they were then interested only in symptomatic carriers, so those who were carriers and also had reduced levels and were symptomatic. And what they observed, this is carrier 1 and carrier 2. I'm not going to go into detail in their stories, but basically at around age 15, if these were their baselines, you can see that their factor 9 levels rose without any intervention. And by age around 20, they had levels that were basically making them asymptomatic. They have gone on to start families without needing any intervention. The last paper was also from Ireland. They also looked at patients who were diagnosed with hemophilia B laden. They divided them into 2 groups based on the age at diagnosis. So the first group, they were all diagnosed before the age of 1 year. Then the second group, they were diagnosed after the age of 1 year. And they basically measured their factor IX levels at different intervals at 1 year and 2 to 3 years. And as you can see, these ones were measured at 5 to 15 years, and then at the different age groups in the brackets. And what they showed was that there was actually a recovery of the factor IX levels as they were getting older. But what's the main thing about this paper is that the recovery was actually not around puberty, because you're getting these patients who were diagnosed before 1 year who are also getting recovery at around 2 to 3 years. So they also supported the postulation of it has something to do with the growth hormone. They also said they don't think it has anything to do with the male sex hormone, but in terms of when the recovery takes place, they think it depends on the mutation that you might have, which I find a bit strange because all of the cohorts in this study had 1 single mutation, and therefore the heterogeneity of the recovery points, I'm not sure how they come to the conclusion that it depends which mutation you have. So in terms of all these papers, what I can summarize is that hemophilia B is a recognized entity which is characterized by low factor IX pre-puberty. And these factor IX levels tend to rise close to normal after puberty. The mutations and most mutations that have been described are in the latent specific region, which is in the promoter region. And the mechanisms of the correction remain like an ongoing research topic. So currently the postulation favors that the pubertal recovery is actually mediated by the growth hormone. So when I had the discussion at the Hemophilia Academy, in addition to referring us to the rheumatology clinicians, they also offered to sequence our patient's factor IX gene for free. And they basically sequenced the promoter region. And recently we got our results back, and unfortunately our patient does not have a mutation in the promoter region. This is just for those who are French, they describe the methodology that they use, but what I wanted to highlight is that they basically sequenced just the promoter region and no mutation was found in the promoter region. So in summary, we're sitting with a 16-year-old who was previously diagnosed with hemophilia B at age 11. His baseline factor IX was 12 at the time of diagnosis. He's got obvious evidence of joint arthropathy. And on ultrasound, there's evidence of hematolosis. He hasn't had any bleeding episode except that 1 query bleeding event where he was given Novo-7. Outside of that, he's been fine. He's sitting now with normal factor IX levels. The NGS sequencing of the promoter region is showing no evidence of a mutation. He's been seen by the pediatric rheumatologist at Bara, and on his last visit in October, he reported having morning stiffness for the first time. And because of that history, they have decided to start him on a trial of methotrexate. So he's going to be seen in 3 months to see if he responds to that. So at this point, we're hoping for some engagement where if anyone in the audience has got something that they think they can add on, or advice where they think of additional things that we can look at or other potential diagnosis, we open for discussion. So we were sitting with a differential of, was this a wrong diagnosis at the time of diagnosis, and this was actually just arthritis, or is this hemophilia B laden? If they say they've looked at the whole promoter region and they haven't found a mutation, then it leaves us the possibility then being unlikely, as opposed to if they had looked for the specific known mutations and would maybe say he might have a mutation that has not been described yet. I'd like to acknowledge all the people who have contributed in helping us to get basically all the information. Thank you.
Thank you so much, Lumka, for a very interesting case and the discussion of a very interesting topic. So there is a question in the chat, and that's also a question that I was thinking about, and that is sustainability of growth hormone, if that is the factor that brings in the change. So Jacques asks, what happens with factor 9 levels later in adult life when the growth hormone levels drop after the pubertal spike and the growth hormone production? I don't know if you have read anything about that. How is it sustained then that you have a factor 8 level that's expressed more than 30%?
Nobody has looked at growth hormone levels, like measured growth hormone levels for these patients later on. But what they all have confirmed is that they remain asymptomatic and their levels remain above 30% most, even into adulthood. Which then brings to, I think there's still going to be another postulation about what's causing the recovery, just that currently we're sitting at growth hormone.
So it seems that one has almost the same effect that gene therapy would bring. You know, changing someone from, say, even severe, because you can start out with hemophilia B laden at 1% or less than 1% factor 9 level, and now it changes to about 30%, which is interesting and sustainable. So even now at the last Massic Education Symposium 2 weeks ago, Alok Srivastava had a discussion about factor levels, and most of the rare bleeding disorders, you don't have to normalize the factor level to more than 50%. You only have to increase the factor level to between 25 and 30% for patients not to bleed. And I think that's an important concept, because that also, and that was his experience, even factor 8, and that's enigmatic, because we think about 30%, and I don't think there's any evidence that was published before to say if I increase the factor 8 level to 30%, the patient's going to stop bleeding. But we've been doing that in terms of guidelines, and it seemed to work. And it is similar with all of the other clotting factors, basically. And that's why they introduced the low dose practice into the World Federation of Hemophilia guideline for surgery that says I can use much less, and the patient will probably have similar outcomes to the high dose practice, which I think is interesting. The other thing is, why would a patient that has a factor 9 level of about 12% or 27% not flag on your PTT test? Because if we think about that, the CLSI guideline says that every laboratory that does clotting factors should ensure the sensitivity of the reagent analyzer combination so that at a level of 30% or less, your APTT would flag and become prolonged. And I just wonder if that is something that the people in the audience are doing in their labs, or is it something that we neglect to do? So that's the first thing. The second thing is, in one of those, you've shown that the factor 8 level was high. It wasn't that high, 187, I think. And could an elevated factor 8 mask the presence of an intrinsic coagulation factor that's low? I would like to hear what the audience say about that. So Dr. Wang says, very interesting case indeed. It is always thought the Leiden phenotype would be in the mild hemophilia B after puberty by adulthood. This seems to be well above the normal levels. Would it be possible for Rosalind to sequence other exons and not promoter regions? So other exons and not promoter regions. Is this something that you have asked about, Lumka?
I have asked and I'm waiting for a response, bearing in mind that this was a freebie, so I'm cautious not to push. But I have asked especially the main guy who's in the lab, because Dr. Rosalind is the clinician and she had referred us to the lab personnel.
I think that they will be looking favorably upon this since we're from Africa and all. Abigail makes a comment to say, very interesting case, Lumka, thank you. How frequent is joint arthropathy reported in hemophilia B Leiden cases in literature?
I don't have a percentage, but they do get joint arthropathies. But the comment that was made at the Hemophilia Academy discussion was that the degree of the arthropathy was just not what they normally see with their hemophilia B laden cases, as this was more extensive, and that's why they were leaning more towards us excluding the possibility of juvenile arthritis.
So Prof. Lau says more than 30% of acquired hemophilias are transient and recover spontaneously. Half of these are due to autoimmune conditions, as we know with rheumatoid arthritis and SLE and so on, also vaccinations and so on. Could this be an acquired hemophilia? That is also something that we consider. Why not an acquired hemophilia?
Unfortunately, at the time of diagnosis, there were no autoimmune or inhibitor studies that were done. So at that point, and also the presentation of acquired hemophilia, the age group, I don't know. I've never seen this type of a presentation. Usually the elderly patients with the extensive bruising, etc., etc. But Johan, you can add more.
But Jacques says also the patient responded to Hemasolvex, and that would not be the case if the patient had inhibitors. One, and also, if you think about the usual workup that we do, is that we do, if the APTT is prolonged, we will do a correction study in the lab usually as part of the workup, and you should pick it up if you do that. So, and the patient was not on immune suppression, yes. So, Anne-Louise says she has 3 comments. Thank you for an interesting and excellent presentation. Anne-Louise, do you want to unmute and speak?
Yes, I can do. So what I was going to say, thank you, Lumka. It was an awesome presentation. I just want to know, in these joints of this patient, does he have any synovitis or not? Or is it now getting better since his levels have improved? Okay, that's the one.
According to the ultrasound report, they said there was no evidence of extensive synovitis.
Okay.
But that was just the ones of that we've heard from Bara.
Okay, and then I just want to know, we also have a patient with query factor 9 laden, also presented at a young age with mild factor 9 deficiency, had a few traumatic incidents and incidents with hockey balls and everything, and then came in and his factor 9 is now normal, but now he looks like he's got van Willebrand's disease. So I did see one case right up like that. So his blood's actually gone to the UK for testing, still waiting from Steve Austin for results, so hopefully you get some. And the other comment I wanted to make is that should we not be testing all our mild factor 9s, because we never see them when we do see them, to see in fact maybe their levels have improved.
It was a discussion I had with Johan to say we can't we can never know because we never look for it. And sometimes people disappear from our follow-ups and they're fine. We never actually check what's happening with their levels.
Yeah, it's so interesting. I think maybe we should start looking. Maybe we'll find more. And then obviously we can't support that genetics here, which is a bit of a pity. But I think maybe maybe in the end when we get results, maybe we should write them up, Lumka. Just let me know what you think.
No problem.
So yes, Jacques also says that acquired hemophilia B is very rare. That is true, but not unheard of. So it is still something that I think one should look for. The thing is, if you do have an inhibitor, it would influence all of your intrinsic clotting factor assays, and all of them would basically measure low, and you're going to have to do serial dilutions to see against which clotting factor that is aimed. So Vernon, great case to write up, especially if you can get genetic cause, but even if not, then also very interesting. Great. If there are any other questions, you're welcome to put them in the chat. I would like to take the opportunity to commend Lumka on a very excellent presentation. Thank you so much. I think we all learned a lot. And the nice thing is that presentations like these also loosen some energy. So thank you for that. And thank you for preparing this talk.
I just want to say a big thank you from my side as well. Johan, Lumka, this was fantastic. I learned a lot. I'm sure other people did as well. So really thank you. And thank you for taking the effort, Lumka, to get all that old literature. It's very interesting. I really enjoyed it. And I wonder, way back in 1946, there was an article in Blood titled Pseudo-Haemophilia. And I wonder if they would have put this case under that category if they had a case like this back then. But anyways, that's just for interest's sake. So please use this code. You can just scan that QR code and use it to register your CPD. It's going to take you 30 seconds. And Gerdien, if you can just show the slide with the team that's been working on the deep dive. I'd just like to thank all of them. Great. There you can see the deep dive team who's working hard behind the screen to make it all happen. A big thank you to all of you for getting everything ready week on week on week. It is not to be taken lightly. And we really appreciate it, Prof. Berg, Dr. Kritzinger, and Melanie Davids. So with that, I wish you all a wonderful afternoon and a lovely evening. And thank you again for joining us. And we'll see you again next week. Bye-bye.